medical stuff, and like we can talk about. As Randy knows, I can pretty much talk. So.
We can too. So you fit right in with us. Daddy, you got Randy, you're gonna have your moment. I love you.
Hey,
Go over, Daddy.
come here.
Go over.
Come
I
here,
know
bud.
you're excited.
Come here. Oh, he's like, come here.
He's so excited.
Come on.
I'll always spend a ton of time with him whenever
I would totally
he
pet
comes.
him and let him
So
sit on my lap, but the thing is, I don't want to be covered in
he's
dirt
so
before my
nasty.
lecture, right? But then, or talk before the talk. But anyway.
Awesome. All right, Deb. We got Deb. We got the Amanda. And
we got the Amanda.
the Amanda. Amanda's going down. She needs some help.
I'm telling you what, I'm going down swinging though.
Well, let's go. All right, so Deb has gotten your blood work almost a year, 4 different types of blood work.
Let's
right,
see.
over
I
the last
think
year?
was that one October or was it November?
Well, so you
Something
sent me all kinds of stuff, but
I
the
did.
one that I did the functional blood chemistry analysis on was on your blood that was drawn on August 16th.
Okay, yeah, that just
So very recently.
Yes, last week.
Do you want? I'm sorry. I'm just gonna jump in. Do you want her to say what's been going on with her?
Sure, yeah,
Or
that'd be
you
helpful
jump
because
in?
I haven't actually done an intake at all, so I don't even know
Exactly.
your
We-
symptom. It's
Listen,
like,
we just
nice
met
to meet you.
outside.
Yeah, nice to meet
Nice
you,
to
man.
meet you. We just met outside. Well, one of the things that I guess I'll just go ahead and start is that I have been having some trouble over the past. I've had trouble for the past few years with menopause.
Okay.
With
Yeah,
you know
you
what
and
perimenopause, menopause,
Yeah.
post. I don't know where I'm. I think I'm in post. I'm not sure where I'm at now, but I don't know if there's going to be an end for me. I think I'm one of those people that's going to have menopause forever. I think I'm one of those tragic stories. But hot flashes are absolutely killing me right now.
Night sweats.
Night sweats. Freezing right afterwards. I mean, we're
Yes,
talking.
that's 'cause you're wet.
We're talking a freezing that it's like it's so cold. So it's like I'm super hot, super cold, super hot, super cold, and so I've got that going on. Energy's way down. Stress is super high. I have done a lot with cleaning up my eating. I was just talking and telling about that. It's the
Congratulations, good.
The things I have given up. I feel like, number one, I should look like a supermodel. Number two, I should weigh a whole lot less than from what I used to eat. I don't eat breads anymore, dairy, no more cheese, and there's so much that I've given up. So things have changed as I've gotten older. I'm about to be 54 on 9/11. Is my birthday, and but I'm just super tired. I had this Cleveland test done, this Cleveland Clinic test or whatever, and
That's what you sent me last night.
Yeah.
I looked at all that. That was
And
interesting.
They had all that kind of stuff, and I didn't know that they were doing any type of a genetic testing on there. So I was very shocked whenever the thing that is it APO? Yeah,
ApoE4.
So one thing it upset my daughter a lot because I didn't realize that was going to be a part of it. She said, "Mom, you really should know something like that. Whenever it's not like it makes you feel like instantly, I start bawling, crying, and I'm like, oh my God, I've got Alzheimer's.
Yeah, like you have a diagnosis.
Like
or
I have a
something.
diagnosis
Nothing
of it.
like
so,
that.
so that's not what it means. I've learned that later. But that day, had I known, I would have took somebody with me to have those results read to me. So
Like me or something.
Yeah, exactly. That's right.
I'm like,
So-
oh yeah, this is no problem. We're gonna-
Exactly. So I'm sitting there and I'm all cocky and like, I got all this blood work, all this stuff. Well, and I'm not kidding you. The doctor started reading this. Your cholesterol's this high. Your triglycerides are this high. Your insulin is this high. And you got this APOE. And I'm like,
You're speaking Greek.
Well, I
Yes,
stopped her and I said, I'm sorry. I said, I'm not trying to be offensive. I said, but are those mine? I didn't know those were my results. I thought she had the wrong paperwork. I thought she had just read the wrong labs. And I was serious with her. And I was like, this can't be me. Well, I mean, we're talking everything going down. And then
They present this stuff the wrong way.
it was so dramatic. It was like,
Yeah, I told
and then I just
Randy.
went home and I'm like, so.
I told Randy, I said, I'm going to be telling you a lot of positives. Like, you're
Yes.
remarkably healthy.
Oh, yeah, no,
So
I
I'm
was
gonna,
not.
I was impressed with your blood work. There's just a couple little things that seem to be a genetic predisposition, which we need to figure out how do we what can we do to help you,
Yeah.
deal with it? But otherwise, like, your blood work is not bad at all.
Well, they didn't say nothing.
but I'm going to tell you exactly.
See, and I'm glad
specifically
you said
how.
that, because the insulin, what's concerning me of so much, of course, is that where I'm getting so exhausted. I never was like that, okay?
Yeah.
And then from the blood work
That
from the
could be-
Cleveland test last year to my insulin this year, it's climbing.
Mm-hmm.
My triglycerides climbing, and it's like nothing that I'm doing is bringing it down. So
Mm-hmm.
it's like, okay, I've really got to stop whatever it is that's doing this, and I
Yeah,
don't know what
yeah.
it is.
Yeah.
So
I think you have a combination of things
Yeah.
going on. So, but largely, I think this is just a genetic predisposition combined with, insulin is a hormone, and so is, when you're going through perimenopause. That's all.
Yes.
Our hormones in our body are like a tapestry, and they all weave together. And so you are going through some hormonal changes.
can you tell where I'm at because it's less
Yes,
than 15
I'll
is
draw
my
some.
estrogen.
I'll draw it on the board. Some things.
Okay,
and I'll show you
good.
some pictures, but you can't see it, so I'll have to just draw it on
Yeah.
the board. But it'll make a lot more sense what's going on once I
Good.
describe some things. But I looked for the biomarker that I like to see in order to gauge where a woman is at in terms of menopause, perimenopause, and
yes.
is the FSH, because FSH
Yes,
is very helpful.
okay.
And I didn't see that one. I would love to see that for you, because then we can track it and I'll
Because
explain
I
why.
have more, so I only sent you 2 sets. I have had probably 4 blood works since last October.
Great. So eventually,
So there's a road.
I'm glad you didn't avalanche it all on me
I
at
know.
once, because I only had a couple days here to
Yeah.
get this ready. But the thing is, I would like to see it all actually.
Yes.
eventually. And then I can put all the trends together, and we
Absolutely.
can. And it'll make a lot more sense, and
Yeah.
it lets me do the deep dive that I do, because
Yes,
that's what
perfect.
other doctors, and it's not their fault. Conventional medicine doctors just don't have time. It's the way our medical model is designed. They don't have time to do what I do.
Right, they do not. They
yeah.
do not.
And
But
that's what I do.
And my doctor, I have a new doctor. She's new to me the last 6-8 months, I
Mm-hmm.
would say, and she is wonderful. And she is. You mentioned anything about holistic and stuff? She's very open to
Good.
it. So that's a rarity, because they
Mm-hmm.
they just don't. And she is kind of perplexed right now because one of the things that I probably need to tell you, I don't know if you even know this, but I went. I
don't know much.
I'm on a shot.
Okay.
And I started out this shot, the semaglutide.
Okay.
Okay, I started.
I was
that
going to
out
ask you actually about that.
about probably about a year and a half ago or something like that.
Okay.
Okay, so I went from semaglutide.
Are you doing it now?
Well, I'm doing the Mounjaro, but it's not the actual brand. So it's I guess they compound it.
Okay.
So this is what I was concerned with my doctor the other day. Whenever I met with her, we was going over the results. I said, "What would my insulin be had I not been on this shot?"
Higher,
Because
probably.
this is it's going to be crazy. So I'm on that shot, and things aren't going because I didn't want to be on the shot anymore. I'm not losing any weight. I'm staying stuck at like 185, and I said, "Why am I paying $400 and something a month for this shot that ain't even working for that?" Now I'm finding out all these other health things, and it's like that wasn't even. It started out as just losing weight, but now it's like, oh my God, like there's like health
What about
concerns
the
here.
water pill, man? We forgot.
So this is the 2 things that I'm on right now.
I think I saw that on your stuff
That's
too.
that water pill that I have been on for I bet 20 years.
And it's for your blood pressure, right? So like
no, it was for swelling.
Okay,
so
so like
I'm
edema.
a swelling. Yeah,
Okay.
I'm a swelling person. So if I don't take that,
I was going to ask you
after-
why you're taking that.
You're
I
a
have it on here.
sweller.
I'm a swell, and I have
Sweller.
been that way since I was a teenager.
So the hydrochlorothiazide is what it is.
Yeah,
Plus
and-
this.
but that does work
triamphorine.
for blood pressure,
Yes, it
right?
does. Yep.
So,
mhm, yeah.
so anyway,
that's
so
why I thought
will-
it was for blood pressure. So I
You
was
know
going to
what?
ask
That's
you.
why you always got a better blood pressure than me. You cheat.
Too bad, so sad. Hey, you got to win. How you got to win? So,
Yeah,
but
I
then
had both
she
those
just
written
put
down.
me on the progesterone, and she just upped it. She wanted to increase it because I am not sleeping. You can probably tell that. I am just exhausted.
look
So,
great.
I'm telling you.
But if you're not sleeping, this is perimenopause. This
It's
is what
driving
it
me
is.
crazy. So I'm in peri. So is that? Have I not
suspect.
hit it?
I'm suspect. No. And so we're gonna. I have some great graphs that maybe I can share later.
Yeah.
But I'll draw them up here
Okay,
a little
good.
bit. But yeah, it's gonna make a lot more sense when I show you
Good.
some pictures.
Okay.
And yeah, there is an end in sight. Once you are actually in full-fledged menopause, then all this wonky estrogen, progesterone, back and forth goes like
Yes.
this will just start stabilizing.
Good.
Right? And then FSH and LH go way up. And so that's why that's a whole other conversation
See,
that I
that's
can go
so
into
great
depth on.
because I have been dealing with this for so long. Literally, because I only have my ovaries. I had a partial hysterectomy, and so after that, that's when everything started going just like crazy. And then I even went to get the pellets that you get inserted in your hip and stuff like that. And those, they did good, but I think they gave me too much testosterone in the beginning. My hair changed. It got thinner. It got more brittle. Things changed. I didn't have hot flashes, but everything else was going crazy. I was like, something's not right. So I probably had those pellets 4 or 5 times that I went and did that, and then I quit doing them.
Yeah.
So I've been trying everything, and
and this,
shooting at nothing and hitting it every time. So
we could just go. So we got to make a decision here because we have limited time. We may have to have the really in-depth perimenopause conversation, like maybe at another podcast.
Another
'cause
time.
There's so much good information there that I need to go into, but I really want you to. I want to show you what I found on your functional blood chemistry analysis. Okay,
yes.
and then we'll go back to that.
Okay. If not, we'll do it at another time because it's
super
so
important.
many women. So many
I know
women.
this because I have many clients
My
and I
goodness.
go through this whole conversation. I had a Zoom conversation with a client yesterday. I went through the same conversation. I'm like, I need to make a document so that I can just show people.
Yeah, just passing it out.
Because
Exactly.
I'm saying the same thing to so and then the women are like, oh, this makes so much sense. What's been happening to me?
Yes. Because believe me, we're all confused.
Yeah. Well, that's because none of us are told anything, right?
Nothing.
Unless you go to medical school.
No, it's just you get hot and that's it. It's
Yeah.
not.
No. It's a much
There's
more
way
confusing.
more.
And I think because remember, I am trained as a naturopathic doctor, and I'm a licensed naturopathic physician, but just not in the state of Tennessee. So I just want to state that. So I'm only a natural health education consultant.
Right.
Okay,
Perfect.
all right.
Yeah.
So, but from my training and my tendencies, the way I like to practice what I do, I would prefer women who are in perimenopause to try to not take any kind of exogenous, that means external, outside your body, hormones like estrogen, progesterone, because things are changing wildly for about 5 years or more.
Yes.
And so 1 month you may be high in progesterone, the next month you might be low.
Wow.
And then you might be estrogen low, then hot, so that you're trying to correct it. And you kept saying you're shooting and missing. It's because it flips, and then it flip-flops again, and then it flip-flops again, and then it flip-flops, and it does that for 5 years. So like taking something, it might be helping 1 month, but then 2 months later it's going to be doing the opposite.
Yeah.
Does that make sense?
Yes, because I would take stuff and do it for a while, then it would be different, and I'm like, and then when
You're
I
like,
felt
why
like
is it work, but now it's not working?
it's
Well,
not
that's
working,
why. And so I tell
the
people
estrogen too was like I would take it. I felt like I was gaining weight with it, so I quit taking it. I
So,
was like,
so I tell people you're sort of, it's a no-win proposition in a lot of ways when you're in perimenopause because things are flip-flopping too much, and so you need to just this is my personal professional opinion, you deal with the symptoms as they come. You're like, oh, this is and once you understand what a progesterone excess feels like and what a deficiency feels like, for you, and I teach people how to recognize that, then, and same way with estrogen, then you can do stuff for the symptoms when it's happening.
Correct.
So you can manage it.
Yeah.
And it gets less and less and less and less until finally when you're in official menopause, and you're solidly in there, which means your FSH is usually right around 130, which is a menstruating woman, her FSH and LH, that's luteinizing hormone and follicle stimulating hormone, they go up and down for your cycle, but they only go between 4 and 21. That's it. So high FSH is like 21, right? Well, the thing is, in menopause, this is how I know if someone's in perimenopause. If they're at 60 FSH, that's not quite menopause because you should be over 100, right?
see.
You're in perimenopause because you're over 21.
so where am I at?
I don't know.
Oh, okay.
I looked for your
We'll find out.
FSH. I want to know, right?
Yeah,
but
I'll find
everything
it.
else I suspected by looking at your estrogen and some other things, I was like, okay, you're probably in perimenopause, which means you're in the wonky phase, right?
I feel it. Yeah.
And so it's very difficult to
makes sense.
give you a prescription and say, just take this, that's going to solve it. Because
Right.
you don't know.
Because you
it's
have
change.
the people telling the doctor, they have the pressure on them. It's like, I'm hot. I need something.
That's right. And so maybe they're giving you the right thing for that moment, but
For that
then
moment.
2 months later, it's going to change.
Correct.
So
I didn't know
perimenopause
that.
is difficult to manage, right? And so I just try to educate women on how to manage it, how
Yep.
to recognize the symptoms for them, and then get through this 5 to 6 years. Some women it can be longer, a lot longer.
Yeah.
But then it does get better, and I'll just give my information. Menopause officially starts when you have not menstruated for 12 months for 1
Okay.
year. Okay.
Yep.
So
Mine was a long time ago then.
so normal, what we consider menopause time frame for women is between 45 and 55. If you are in menopause before that, it's premature menopause, right? Or considered late. And these are
Well, mine,
diagnosable.
I forced mine because I had the partial
Right,
hysterectomy.
that's right. Yeah. So you had a surgically induced
Yes.
menopause. So like for me, I define the early part of normal. Okay, so like I stopped menstruating very early, but remember it's still considered normal because I'm just at the very beginning of
Yes,
normal. Does that make
right.
sense? So
Yep.
44 years old, I stopped.
Really?
So 45, almost.
It is early.
So, but remember, not early according to diagnosable.
Right. I see. I understand.
Right,
Yes.
but if it was a month earlier, yes.
Okay. Yeah, I
Right?
get it.
Okay.
Right.
I define the
Right.
early edge of the normal.
Right.
Because 45 to 55 is when we
Well,
expect
that's
people to
it.
be in menopause. So I stopped at 44 years old,
Mm-hmm.
and then so 12 months. At 45, I had
That's
not menstruated,
menopause.
so I was in menopause at 45.
Wow.
Okay. And so I was like, well, what did I do wrong? I was thinking, am
Mm-hmm.
I not healthy? All those are misconceptions. I did not take birth control, so I was thinking in my head that maybe I just used up my eggs faster because I didn't have birth control. But I
Right.
have an identical twin sister, and she has had 3 children. I've had no children. She was on birth control throughout her whole life,
Yeah.
and she stopped menstruating the exact same month.
The same time. Oh my gosh, really?
Yeah, I think it's
Okay.
dialed in, man.
Yeah.
Just dial in your
Wow.
genes, right?
My
It
goodness.
It doesn't. We've lived completely different lives in a lot of respects, and yet it was like to the month.
That's crazy.
So, I just think that it's one of those genetic, things that are just in your DNA. So anyway, be that as it may. So then, like for me, menopause, if you consider that the middle, the 5 years before and even the 5 years after can be this fluctuating time zone.
Right.
Does that make sense?
Yep,
Like fluctuate.
it does.
So
Yep.
so for me, it would be like starting at 39 to 44. I was going through a lot of the wonkiness.
So
right.
you were doing the perimenopause then. Wow.
39 to 44, right?
Jeez.
And sometimes it'll last 7 years. So like 2 years after that menopause date, you're still having some weird stabilization. But then now I'm solidly in because I'm going to be turning 51 here in a week or so.
Yeah.
And so I
Oh, it's your birthday when mine is?
August 29th.
Oh, the 29th. Oh, I forgot we're still in
When
August.
Foster's birthday is.
Is it really?
My birthday.
Yeah.
So anyway, so that's when I'll turn 51, and so that'll be 6 years into menopause for me. So I'm nice and stable, which is great. So, but I've gone through it all, man. The night
Yes.
sweats and all of it, right?
It's the worst.
Yeah, I know exactly what everyone's going
You know
through.
what irritates me too, and I just almost can't believe this, but I mean, I don't like to call people liars, but there are women who'll say, "Oh, I didn't go through anything."
Well, maybe they
Well,
didn't.
good for you. Praise the Lord. Praise the Lord for you.
You know what? I need help. I mean, this is why. This is.
Are you going through menopause?
Me.
So it's interesting. I was an engineer, and I remember at 39, like standing at the water cooler or whatever, getting before a meeting.
Yeah.
And I would have my my collared shirt, and my
Yes.
pants, and I'd be standing there. I mean, literally, it's like a room like this, nice and air conditioned.
Yeah, it's
no
fine.
stress. I'm not stressed out about anything.
Nope.
And then I would just drip
Yeah.
from my armpits. So it would like soak my shirt, and it would make me look like I was nervous. But I'm like, I'm not
Yes.
nervous. It's just dripping. It would drip down my legs, and I'd be
Yeah.
like, "Excuse me, I'm going to go to the bathroom."
My
And so-
back will get wet. The back of my
like
neck.
dripping liquid.
Yeah,
That was
crazy.
dripping. It was crazy. And so I'm like, what
Out
is
of
going on? It's like, do
nowhere.
I have tear ducts in my arm? Oh, I'm not even working out. This
Yeah,
is ridiculous.
it is.
And so it was all hormonal. And so I had to actually buy these little things that you would put on your shirts to like absorb, sort of like a
Yes.
maxi pad for your
Yes,
armpits,
that's right.
So that way I wouldn't soak my shirts when I was at meetings.
Kind of like when they breastfeed and
Yeah, it
stuff
was
like
totally
that.
ridiculous. I'm like, this is
I know.
ridiculous. But I had bags of them, and
Yeah.
and that's how I got through that period without soaking my shirts. And black, I learned black was your friend.
Yes.
Black is your friend.
Black is always right. Look,
The black is your friend, right?
we know.
And so synthetics, nice,
Yes.
So yeah, I've been through it all, and we can talk in depth, and maybe at another one, because
Yeah, sure.
I'll tell you all the tricks. I'll tell you, and just recently, this last week, a woman said, "Deb, can you blend me a botanical tea for hot flashes?" I said, "Sure." And she came to my house, and I gave her a custom blended,
Yes.
tea that I blended with my own herbs that
Yeah.
works really good for hot flashes, right?
Oh, we need the
So,
relief.
Yeah.
We need the relief.
And she's like, I'll just leave, so people pick stuff up from my front porch. I leave it in a bag with their name tag on it, and then they put some money into my porch, So
Yeah.
anyway, the front mat, and that works great. So there's so many things we can talk about with that.
Yeah.
But for you, yes, it looks like I would like to see. I suspect you're probably around 60, which is like right in the middle of perimenopause, which
Okay.
is the worst.
Oh yeah. Oh, it is the worst. Yeah. It is the worst.
But it's all very, very
See?
manageable. It's very manageable.
Some of these feel sorry for me.
No one feels sorry for you. Not in this podcast, Randy.
Yeah. So I'm putting this here. Hopefully you can see it, but I'm going to be emailing this to you. This is my
Okay.
functional blood chemistry report. As you can see, it's long. It's 67 pages, but a lot of this is just information. So I'm going to skim through it, and we can go
Okay.
back and forth.
Yep.
Okay, but please, anyone I do this report for, I encourage them to text me more questions when they look at it, but it's a little bit of information overwhelm, but I'll try to distill it down to the essence. So this is table of contents. Okay, great. So now, a functional blood chemistry analysis, this part talks about what it is, okay? Like, what is an FBCA? Basically, we don't look at the blood biomarkers from in isolation, meaning just by themselves. Like, usually you get your blood work back and it's like, everything looks fine, but you'll see an L in parentheses for low and an H in
Yes,
parentheses for
for
high,
high.
and that's it. That's all you get, right?
Yeah.
And so the doctor skims over, oh yeah, this was low, this was high, but
there's
they're not
no
even
explanation.
they're not even looking at any
Yeah.
of the other ones. If it doesn't have an L or an H, their eyes go right by it.
Correct.
Okay. That's not how we look at this. We don't look at things from a functional standpoint in isolation. I'm looking at, you might be within the normal threshold for this one, but you might be high normal, and then low normal.
Yes.
And then when you put them together in this overlapping like constellation, that's a trend towards something.
Because I would see one that I was only like one little point away from being high. And I'm like, well, wait a minute, isn't that important? That I'm
right.
almost there, but it said normal.
Yeah, and then you might ask too, where do they even get these thresholds from,
Yeah.
right? And it's a mixed bag how they even come up with the thresholds. So for this, this is the thresholds of what's considered high and low are completely different.
Yeah.
These are based on optimal health, not a normal distribution of a demographic population.
Right.
Of
Okay.
what. So if everyone's unhealthy in that population and everyone dies of cancer, then you're wrong track.
Yes, exactly.
Right, you know?
Correct. Yeah.
Right? You are
Yep.
normal. You're right in the middle. You're on the road.
Yes.
So, now that's a little bit of an exaggeration. There are some.
But it gets the point across. I
Yeah,
understand.
right.
Yeah.
So we don't care about what's typical. We
Yep.
want what is going to optimize your health. So this is a little bit of nitpicking. We're really nitpicking. A ideal, like Plato's ideal person. What is an ideal optimal health, and where do you stand?
Right.
Okay.
Exactly. Instead of it being from you're normal today and tomorrow, oh my God, everything's high.
That's
like,
right.
oh my God,
Right.
when did this happen? When we could have done something
That's
in
right.
the middle.
That's right. We need to see the trends as they're happening
Yes.
and piece together a holistic
Okay.
picture.
Got
so
it.
we're looking at them with different highs and low values, and we're also looking at it together.
Okay,
All right. So we're going to skim through a lot of it.
That's fine.
But that's what this describes. What I just said. That's whole part of the report. So you can read about it. Okay. And then I usually, run the practitioner report, which gives more information because I figure you guys can. If you're hiring me to do this, you want
Yeah.
the information.
Yes.
I would rather you have as much information as possible.
Oh, yeah.
So I assume that you.
And we'll sit there in the bed, and all of us women, read it and all that stuff. We
That's
will
right.
read
Yeah.
it. So.
Some people won't, but at least you got it. Right?
At least
The
you got
information's
it.
there, and then you can ask me questions. Like you're like, I read this, and
What does that mean?
That's right.
Yeah.
And sometimes you forget to tell me a piece of information, but if you're
Correct.
reading the report, you're like, oh no, that I forgot to tell Dr. Deb that.
That's right.
Okay. All right, so when I look at this first part of the report, I'm just like I said, I skim it a little bit. I'm just sort of blurring my eyes and looking to see where you fall.
Right.
Okay? And so I'm like, okay, yeah, that's interesting, So then I think, as soon as I saw this insulin was high,
Yes.
I'm like, but your blood glucose is good.
I'd have never known it had I not taken that
And then I'm like,
test.
well, wait a minute, your insulin is high, but your A1C is okay.
I know.
And so then that made me go like this.
Yeah.
Right? Because that's
Like,
usually.
why?
Yeah, that's genetics anyway. So then I'm like, but that was interesting. That piqued my interest. And so this is all because of these these are calculations. Don't worry about any of that.
Okay.
I'm skimming it. But this was interesting. We would like to get that lower for sure to lower your cardiovascular risk. It's liver enzymes, ALT and AST, their ratio is called the Diritis ratio, and I'll go into that more depth, but we want it around 1. You know, that's where I would like to see it.
Oh, is one way over there?
Yeah, way over here. And so we're gonna, so your liver is having a response to what's going on. So,
Yeah.
but we can fix this. We can
Okay.
always fix both.
Do I
Okay.
have a fatty liver? Does that show that?
It can, yes, but I don't think so. No.
Okay, good.
Okay.
Okay.
I don't. You're trending that way though.
Yeah.
But I don't think it's because of the normal reasons. I think it's
I know.
it's because of your high insulin, which I think is a genetic predisposition, and because of that,
That
high
makes
insulin,
sense.
it's causing you to have high triglycerides.
Yes.
So that's the cause, I believe, of your high triglycerides is your high insulin.
Instead of because I keep trying to correct my food, not to say that it doesn't need work, but it's not to the level that
No,
of,
this is-
of having this high level.
No, so we need to,
Okay.
it's sort of like, I'm sure people have heard the cytokine storm and this cascade of events starts happening and you got to like reverse it. you know?
Yes.
Well, I think you're in this
Because
sort of,
it's going every blood work that I've had, more, and it's like, wow, it's jumping fast.
yeah, so we just got to reverse it
Yeah.
and there's things we can do.
Slow it
okay.
down here.
All right. So then triglycerides are the ratio, but triglycerides to glucose is high. We
Yeah.
want that around 4.4. So, but it's not as bad as I've seen. It's not that bad. Okay.
Oh, good.
So remember, the red looks scary on some of these.
It looks very scary.
But this is optimal. Like no one has. I've never seen anyone with a perfect ideal. You know,
Yeah.
even 22-year-olds, right?
Oh, not even Randy?
Not even
Darn
Randy.
close.
If we're in a competition here, I'd say I'd like your blood work better than Randy's.
Ah!
It's on video. That is on video.
Yeah.
Yeah, well, you're on blood pressure meds.
That was the cure-all right there. And it
there's-
is a competition.
Yeah. If it is a competition, if I had
It
to like
is.
just it's merge the whole report and whose do I like better? Yeah.
Oh, yeah, when she did mine, she goes, oh, well, you're the best I've ever seen. Now I'm like, oh,
Well, it's a
okay.
different day, Randy.
It's a different
Top
day.
down.
All right. Okay. So I really loved your kidney function. Great. That's fantastic.
Oh, good.
Okay. And even though this says below optimal for GFR, that's not true because this is a stupid computer program, an algorithm, and it does not age adjust. So like it doesn't adjust for your age. But I know that that's great. I
Good.
wouldn't mind seeing it a little higher, but honestly, all these other numbers, like you're great. So kidney function is great. Electrolytes, fantastic. You're doing great with your electrolytes. I'm very, very pleased. You're like couldn't be better actually. I mean, dead nuts middle, optimal for everything. Sodium, potassium,
Wow.
chloride, all of this. Okay, so that's great.
How'd that happen?
And even your anion gap, and I'll tell you what that is a little bit. It's a little on the high side, but it's not really bad. I mean, anything that's not in the high zones
Yes.
here, like I'm
Yeah.
happy with.
Mhm,
Okay,
good.
it's something to keep in mind. And usually when I see this, oops, I didn't mean to do that. Give me a second. You know,
Oh, it's
it's
okay.
so sensitive. It means to me usually it would behoove you to try to focus on eating maybe a little bit more dark leafy green vegetables. This means your blood is a little bit more acidic than
Yes.
alkaline, just a little bit. And so who cares, except that remember, if you want to create an anti-cancer terrain in your body,
Correct.
cancer likes acidic environments and not alkaline environments.
Right.
So for overall health, I would rather see you a little more alkaline. It's sort of like getting the soil in your garden ready for a
Yes, getting
particular
it right.
plant, right?
I see.
We're just trying to create an anti-cancer terrain. So
Perfect.
let's, that would be, a little bit more leafy green vegetables. Like some
Okay.
people will take like a chlorella spirulina tablet, and
Yes.
they'll eat a couple of those. That's just food, and that's a fantastic way to get.
Well, that would be the only
creative.
way leafy greens is going to get in me. That'd
Me
probably,
too.
That'd be it.
That's why I mentioned it, just because it's
Yeah.
hard for me to get enough as well. So I'll just eat
I've
some
never
of those.
been a salad person. I mean, I'm never going to do it.
That's right.
I'll buy it all. I'll get excited.
and
I'll
then
fix
it,
the
and then
salad
it rots
that
in
night,
your refrigerator.
and then it rots in the refrigerator.
That's right. I
so.
get it completely. That's why I
Okay.
mentioned now. And the thing is, the chlorella spirulina. You can get it in a powder, and I think it's disgusting.
Yeah,
And
Randy used to do
Oh my God,
that
it's so gross.
spirulina,
So like some women
whatever
are
it
like,
is.
no problem. I'll drink my greens. I'm like, great. If you can do that.
Have at it.
But
I
for-
need something that.
For me, just need the little tablets.
Me
and
too.
I'll have 7 or 8 of them, because it's food, right? And I just
Absolutely.
swallow them while I'm,
I can do that.
That's no big
Yes.
deal. And then you can make a big difference here.
Okay, good.
At least where you're at.
On
Some
that.
people are really high, they can't, but that's what I would probably recommend for you.
Okay.
So protein, I was super pleased with your protein because you're in the 7s, you're almost 7.5, you're 7.3, which is fantastic. So if I see people lower than optimal protein, it usually means their stomach acid is a little not high enough. Okay,
Oh.
like hypochlorhydria, which is a low stomach acid, and it means they're not breaking up their peptide chains efficiently.
Because you want a lot really strong acid to get rid of all
That's
the
right. So
good
usually
stuff.
when I see that, that means, okay, you're eating your protein and your stomach acid's high enough to absorb it.
Good. Okay.
You're getting it where you need it, which is great because as we get older, sarcopenia, that's muscle wasting, is a big a reality,
yes.
and like I'm not worried about that for you.
Oh, good.
Okay,
Good.
so great, and your albumin's a little bit low, but all this looks good. I love this. Your protein's great, so great. So then minerals looks great, so I'm happy about that. Their calcium, we'll talk about. It's in the optimal zone, but for you, I consider that high.
Okay.
Okay.
Yeah.
And the reason why is because you have this cholesterol, triglyceride,
Yes.
insulin issue going
Problem.
on. And I hate to call it a problem. It's an issue.
Yeah.
We're going to deal with it. But
We're gonna deal
it's
with
a
it.
tendency,
Yeah.
right? For
Yeah, there you go.
Right? Okay. And so what we have to do is I want to make sure you don't have excessive calcium floating around in your bloodstream that could stick to the arterial walls, the endothelial lining, to contribute potentially to an atherosclerosis picture. Does that make
no,
sense?
I don't want that. I don't know what that is.
Let's-
I don't want
I've got a
that.
little bit of
That's
that.
plaque buildup.
Okay, so now I had that test. Do you remember what that test is?
Calcium test.
So I
Coronary
had that,
artery calcium.
And I got a 0.
Thank you. That's great.
At
So
0.
to keep that going in that direction, okay?
Yeah, so I want to stay on that.
We want this a little lower, okay? Because of your picture, your whole picture, okay?
Yeah.
I love that your coronary artery calcium score is low.
Yes.
I'm actually not surprised because if you look a little lower, we haven't got to it. Your athero index, you had a couple factors that said you were low, so I knew that was probably
good.
not a good. But I would still want to make sure your calcium's low enough. Now this is higher than I would expect to see in most people. But then I looked and saw what your supplements are, and you are supplementing, at least you were at some point, with 50,000 IUs of vitamin D3 a week.
You know what? I knew there was something else I was supposed to pick up at the pharmacy, and I take it once a week. And then, but once I empty a bottle, I'll forget, and then I don't go back and get it. So I haven't took that in a while.
Okay, that's okay.
Probably in about a month.
Okay, so but I
Was
can
it
tell
too
you
high?
no. So I'm gonna spend a minute here. We're gonna have to do this in phases.
Okay,
So
yeah, there's a lot.
It's gonna be a
Yeah.
lot, and sometimes, as Randy knows, it can last a long time. But all right, so I'm gonna talk to you a little bit about some fat-soluble vitamins. Okay, so D3 is what you're taking, and
Yeah.
right now you're taking 50,000, right?
Yep.
IUs a week.
Right.
All right. So IUs a week. Okay. All right. But this is the fat soluble vitamin pyramid here. But I consider this more. Imagine it like a teeter totter.
Okay.
Okay. So it's balancing. It's all about
Okay.
balance. Okay.
Yes.
And then we've got A, right? And then we're going to have K2, okay? And it can be in two forms, MK7 or MK4, okay? All right. Now, if you put a fat kid on a 3-way teeter-totter, then these two are going to be imbalanced.
True.
Okay?
Yes.
Right.
Yep.
And that's going to have an effect on things in your body.
Okay.
Now, the primary thing that when I see people who are taking a decent amount, that's a decent amount. I wouldn't
Yes.
call it excessive, it's a decent amount.
Okay.
Then I usually see if they've been doing it for a year or so, their calcium will go up in their bloodstream.
Oh.
Okay. And the reason why is D3, even though it's a fat soluble vitamin, it makes the calcium in your food become very bioavailable, which is great because it prevents osteoporosis. We want that
Right.
calcium,
We
right?
need that, right.
Yes, we do. So I'm happy, and it helps your immune system, and there's a million things this does, and I love it. Good job. Great. Okay.
Yes.
But if you put a fat kid on one side, we got to balance it, because if you don't, then your calcium in your blood is going to go up, and calcium has +2, which means it's very sticky. It wants to bind to something to be happy, right?
Yes.
Because it needs 2 electrons, right? And so you don't want it floating around in your bloodstream. You want it immediately. It has to go in your blood because your blood is what transports nutrients, right?
Right.
But then you need it out of your blood quickly. Well, that's what this does. So K2 is the chaperone.
That's why they always said take D3 with K2.
Yes.
But in my mind, when I got that, I get it as a prescription. I don't go in and get
That's
it. I
right.
get it from, and so I just assume they gave me everything I needed. And
Yeah.
that's what you think.
Yes, well, and so the thing is, I love that doctors are now testing blood normally for, COVID really started it, I think, is when doctors really started
probably.
testing their vitamin D levels, which is great, and I'm happy about it. But I don't think that there's been enough training with nutritional training for conventional medicine doctors. Like, I've had a ton of nutrition classes in my curriculum, tons.
Oh,
right?
God, believe me, I can tell.
And so we just had a little bit more. We focused on nutrition as a solution, not just drugs and surgery.
Right.
So I'm happy conventional medicine, and they're doing what they're taught, and that's great. But they're used to, like, you have this problem, I give you this. So you have this problem, and they're trying to use a nutrition approach for that. And
Correct.
and that's great. I love nutritional approaches, but just you got to be careful because there have been studies that show that you can increase your risk of a coronary event by having this increased calcium from taking that.
I see. You're trying to do something good, but then you're not balancing
That's
it
right.
out.
So this will solve the problem.
So how do you get K2 and A?
So most supplements nowadays, they're starting to get smarter, and you'll see D3 and K2
I've seen
together.
them combined.
That's what you want. Okay?
I see.
But if you notice, then that solves two parts of the.
How do you get A? I never hear anybody take an A.
Yeah. So
ever.
Got one called ADK.
ADK.
Are you serious?
And so you're going to see, I'm sure, in a few years that the manufacturers potentially will get smart enough and they'll start making more of these. But there's two brands I really like. Da Vinci Labs is one, and it has an ADK. That's what the supplement is called, ADK.
Okay.
And they have one that's just that, which has 5,000 IUs, and this is important for you because I'm sorry about that. And then there's one that's called ADK 10, okay? And that's because it's 10,000 IUs, okay? And it has the exact right ratios of all three of these.
I see.
Okay? So for this is the rule of thumb now, because remember, there's a lot of information.
Yeah.
For every 1,000 IUs of D3, okay, you want 100 mcgs of K2 in the form of MK4, MK7. I prefer MK7 for people who are in menopause and who have maybe some osteoporosis risk or have osteoarthritis or some other things. So I like MK7, although this is good too. So if there's a mix of those two, that's okay too, okay?
Okay.
And then you want 1,500 mcgs of A.
Okay.
Okay, you're like, dang it, this is getting complicated. How to put all my pills, so if I got to take one of these and three of those and two of those, I'll make this is ridiculous.
Yeah.
This is like, man.
It's a lot.
Yeah. It's like my mother's like, my mother would say, I can't do this, I'm getting overwhelmed, okay, as you should be, because it's ridiculous.
Yeah.
So instead, don't worry about it, just get a supplement
get that
has the right ratios for you.
Wow, that's
There's
great.
another brand called Carlisle that I really like.
Okay.
That's on Amazon.
Okay.
And it has an ADK, and it has more K2 per one right? And I actually like that for a lot of people. And they're little tiny soft gels. The problem, no, it's not a problem, but it's only 5,000. And so, like, depending on if you have osteoporosis or any kind of bone spurs, or like, let's say you have a tendency towards kidney stones, I usually want you to have more K2 because that's gonna take that calcium that's excessive in your system, and it's going to transport it to your bones.
Now, how do you know how much D3 and all that, how much that you need a week? How did they determine I got 50,000 a week? Is that
so?
just...
A lot of this is like professional judgment, right?
Yeah.
So your D, I think, was around in the 40s.
Yes.
Okay. And so I would say that's great. In fact, I might
What's
even...
it supposed to be? 100?
So 90 is like the upper range, 60 to 90, 60 to 90.
60 to 90. Okay.
And I like people usually around 80. There are certain circumstances where I want people's target to be 90,
Okay.
if they have some thyroid issues and other things. So it depends on the person. Like, I have to look at the whole picture to tell you where I want your target to be. You 80, I think 80 would be great for you.
Okay.
75, 80 would be great.
I'm going to get some of that.
So that means double what you've got. You need to double. Okay?
Right.
So I'm okay with with your doctor doing this. That's
Yes.
great. But I wouldn't do it that way, right?
Yeah.
Does that make sense?
Yes.
I would rather you take 80K10.
Yes.
Right? Because it's 10,000 a day. So it's one.
That's
it's
a day.
It's an itty bitty pill, right? But if you do that, then what you're going to end up taking is 70,000
a week.
right?
Yes,
So it's
right.
actually more, but it's spread out every day,
Okay.
and it's in the right ratios. And remember, you need this for skin health. You need this for immune system.
I mean,
you need this for
literally,
your eyes.
I never get this and that. I don't like what foods would even have that.
Okay, so K2, the primary food is natto. It's a Japanese fermented product that tastes
Like kimchi or something,
Tastes
or-
like absolute vomit to me. It's
Ugh.
the worst tasting. Most Americans find natto to be repulsive.
Yes.
And I do.
Yeah.
But I did have a friend of mine who's a Japanese classmate of mine in medical school. She
Yeah.
brought it in, and she loved it. They eat it for breakfast.
They're
And it's-
raised on it,
and it's
though.
very slimy. And,
Oh, my
And
goodness.
it's soup, and that's really
Because
the
it's
food.
fermented.
Yeah.
Oh.
And it's awful. And I like all kinds of Asian foods, but natto I find
No.
really repulsive. And so it's an acquired taste. If you
Yes.
can eat natto, do it, but you gotta do it consistently. I can't do it. The next best food sources are like Gouda cheese.
Yes.
And, but you would have to eat massive
You'd have to eat
quantities.
so much.
Like, it's not even comparable. the
So
amount.
whenever we take supplements like that, on the majority of them probably are okay to take a supplement than to actually eat all the foods because
Yeah.
you can't get enough.
It depends on what we're talking about.
Depends on.
Okay. Like thyroid, no. A lot of people, I tell them, you need selenium, zinc, and iodine, and I want you to get your zinc from a small handful of pumpkin seeds, and that's what I tell people. That's my recommendation. A little,
Yeah.
And I want you to get your selenium from your Brazil nuts. So I want 3 Brazil nuts a day. And so there's a lot of things that I will prescribe.
I
food.
actually took selenium years ago for probably a month, and then I quit doing it because I got scared because I'm self-diagnosing myself. I don't know if I'm lacking. They get on these trends. Oh, everybody's taking this now. Everything gets
Yeah,
trendy.
I feel like that was this.
Oh,
Became
it was very
trendy.
Yeah, so I got scared, so I just took everything out. That's why I don't like a lot of stuff unless
Yeah,
I need it.
I prefer almost always to use food as medicine.
Okay.
But in this particular case, right, especially
that.
with your vitamin D in the low 40s.
Okay.
Yeah, I think, and the thing is, you probably after 6 months or a year, we would check your vitamin D, and
See
if we got it up to where we need it to be, I might then have you go back to this one,
Sure.
which would be half that dose,
Okay.
and then that would be what you would take every day,
Perfect.
right?
Perfect.
And then we can see how it goes, and then maybe you can even take less. But this is a great one that I think almost all of us in menopause and
Absolutely.
if you're not super south in the Caribbean islands getting a lot of
Yes.
sunlight,
Sunlight.
this would be something that most of us could use.
Good.
Okay.
Okay.
So that's that discussion.
Good. That makes sense.
We got so much more. We are on page 8 out of 67. All right. So anyway, calcium. So when I saw the calcium, I knew you were supplementing with vitamin D3.
Yes.
That's the first thing I look at is there she is.
There it
Okay,
is.
great. 'Cause
That's
that'll-
it.
If we can pull this down a little bit lower by using that K2, then it's going to lower your risk of we don't want that calcium contributing to increasing your risk of a
Yes.
coronary event.
Okay. Perfect.
Okay.
Yeah,
All right.
I'm-
So let's
I'm
keep
on
going.
that.
Remember, this is all about tons of information. I'm
That's
sorry.
okay.
But your liver looks great. Your ALT's a little high. We can talk about that. That has to do with this insulin and triglyceride
Okay.
issue, right? Okay. So remember, I just blur my eyes, and so then I saw your triglycerides. I'm like, yeah,
They're creeping.
yeah, that's high.
They are creeping.
Yeah, that's
Yeah.
that's so high is 150 and higher, and you're at 405.
Yeah. And it was just 300 and something the last time I went, or 287 or something. I'm like, what is?
So-
it's leaping.
So I texted Randy the night I was working on this, and I said, so does Amanda drink a lot of like tons and tons of sodas? Do you drink tons of sodas?
No.
That's what he said.
No. I used to. I don't know more.
Because typically this is like a lot of hidden fructose. Okay, so high fructose corn syrup is in soda. So people who get the big gulps and they just drink big gulps all day long, or they get Mountain Dews and they just drink them all day long.
Yeah.
Their triglycerides would be high, right?
Okay.
Because it's that high fructose corn syrup.
Yeah.
And fructose is the signal. Okay, like it's the signal that tells your liver to dump triglycerides into your blood.
Wow. Okay.
All right.
Okay.
So normally I'd be like, okay, so she's got to be like a secret candy-aholic.
Something
or
has to
right?
be,
You
yeah.
know? But then so what did I do? I go back and I look at your glucose and I'm like, Yeah, that's not true.
It's not. See,
Because-
it's not true.
Because your glucose is fan-freaking-tastic.
Really?
Yeah, that's great. Right?
That's why nothing
And
was
your
matching. I was
A1C
like, I'm barely. If I was to get a soda, it'd be once every 2 weeks.
Yeah, I believe it. Because
So what's the remedy?
your A1C also can't lie. That's your 3-month blood glucose average, right? So it doesn't lie. So
Yeah.
like you don't have a lot of blood. So people don't understand what
Yeah.
A1C is. Do you understand what
I
A1C
don't.
is?
No.
So one of my instructors at Bastyr University used this phrase, and I've used it. I've adopted it for myself. So, but it's like imagine a bowl of cornflakes, and you could buy frosted flakes, right?
Yeah.
Well, imagine the flakes are your red blood cells, right?
Okay.
And A1C is how frosted are your flakes.
Oh, that's a really good. That's a good example.
Yeah, because basically, if you have glucose in the bloodstream, it will stick to your red blood cells.
see.
It's called glycation, and it sticks sort of like the sugar sticks to a cornflake,
I
right?
see.
And so, a lot of frosting is a higher A1C.
And that tells on you.
Yeah, and it only happens. Red blood cells live for approximately 3 months. That's their lifespan. So this is a 3-month average because the red blood cell dies, and you get a new one, and then they have to be frosted.
Really?
Right, and so it's chronic blood sugar that causes the frosting, right? The glycation. And so if somebody changes their diet completely, you have to wait 3 months and take your A1C again to see if it
That's
actually made
how
a difference.
you know that I'm not going home and secretly eating and
That's how I
drinking
know.
everything.
You can't lie.
I love that.
I mean, you could have a binge one night, right? And that might
Sure.
frost a few flakes, but
But it ain't going to be to the level of like.
right.
Oh my God, that's great. That's awesome.
So
I've been validated.
Yeah,
and I feel validated.
I less care about the spot glucose, and this one is more meaningful to me,
Okay.
right? Because this is 3 months. This is how much of the sugar.
I did not know. Did you know that about 3 months thing? So you get a brand new one, and it's like you have the option to not frost it or frost it.
That's right.
Okay, I like that.
Yeah,
I'll
yeah.
never forget that.
Yeah. How frosted are your flakes? That's
How frosted
A1C.
are your flakes? Oh, start doing some T-shirts that say that.
Right. So basically,
Marketed.
I'm like, okay, well, she is not eating, frosted flakes.
I'm not. I'm not.
Okay, so then I go back and I'm like, well, dang, triglycerides, huh? And then I went
Yeah.
back and I looked at your insulin again, and I'm like, your insulin's high too. I'm like, that's weird, right? And then your HDL's low at 40. That's really low. We want to get that higher. So I'm like, okay, so
Now,
there's
what is the HDL?
so there's low density lipoprotein. There's high density lipoprotein.
Okay.
These are different. I call them fat packages. So the only reason, well, maybe I shouldn't say only, I not use absolutes, but the blood is here to transport things. It's like
Yes.
the highway for the trucks to drop
To
stuff
just
off.
get somewhere.
It's got
okay.
it takes things where
It's
they need
fluid.
to go.
You got to go somewhere.
Yes, we gotta have a transport mechanism
Okay.
to bring the stuff that we eat, the
Right.
nutrients from our intestines to all the places
don't
it
just
goes,
sit
right?
there, right.
Yeah. So it's just a transport. It's like the highway for trucks, right?
Sure.
Okay. So there's different kinds of trucks on the highway, and so you can consider the lipoproteins the fat trucks, the trucks that hold the fat. Okay. And there's different size trucks. You got the triple trucks and the little tiny trucks and the right and so basically that's what we're talking about is how large the fat package is, how fluffy it is versus how dense it
Yes.
is. And then lipoprotein. So if lipo is fat and protein is protein. So basically the protein is an actual exoskeleton that holds the fat in the
Okay.
middle. So that's why they call it a lipoprotein package, because it's
Okay.
like this little protein exoskeleton holding the fat.
Yes. Okay.
So HDL we call the good cholesterol, but I hate using those words because they're all good, honestly.
Okay.
It's just which ones can lead to plaque buildup, right? Okay.
Yes.
And then LDL is our low density, and so it's more of what we call the bad, right? But it's not bad actually. It's been proven in so many cases to actually be super healthy for our brains and preventing Alzheimer's and all kinds of things. And higher cholesterol is also correlated with lower all-cause mortality. all right?
Okay.
So. I'll draw another picture.
I'm having a hot flash.
That's all right. It's because too much information, right? That happens when you're listening carefully.
I am.
Okay, so can the screen see me over here?
Yes.
Possibly?
Yep.
Okay.
Yep.
So this is what I call this a bowl. Okay, so this is a graph. Okay, so and we're going to say this right here. These are cholesterol numbers. So this is your cholesterol on the horizontal axis. All right, cholesterol, total cholesterol. Okay, and this right here is all-cause mortality. So all-cause mortality. That means dying of anything. Okay.
Okay.
And so this is 1, which means this would be you have no increased risk of dying of things, which is what we want. We want to be here. Okay?
Wow.
So what is the cholesterol? What is the total cholesterol? What's that sweet spot, right? It's around 180 to 220.
Okay.
Okay. So people, they if you get your blood work done and you're at 180, they'll say it's still too high. We need to give you statins, and I don't know why that's
I have
said.
been offered statins, and I have turned them down. I think it's like 3 times, and I'm like, there's no way I'm taking that.
Yeah, and so the study of this, I can send it to anybody who's curious. Just tell me you want the study, I'll send it to you. Is based on 12.6 million people. That means epidemiologically speaking, this is very statistically significant.
Yes.
Okay, which means this is probably the sweet spot that you really want to be in.
Yes.
Is between 180 and 200.
Okay.
So, actually, this is like 220. It depends on your age and all kinds of stuff. So, like, I really like 190 to 200. That's and what is your cholesterol?
Yeah. What was my
203.
It ain't
So-
it ain't too bad.
It's not ain't too bad. It's like dead nuts.
That's
perfect.
unbelievable.
You're
But
like-
why is it like that?
So it's like,
That's crazy.
so like, what is your risk of all-cause mortality? Nothing.
Oh no, she's gonna keep living.
So is your
Where's
okay.
my crown? I was wondering where that was at. Where is my crown?
Yeah. So there's some good
Wow.
news in your blood work. Is what I'm trying to tell you.
And mine's
So-
better than yours.
Stop.
So LDL also has a bowl-shaped curve to it, but it looks a little bit different. It's more sort of like, it has a different shape to it, and I have so normally when I'm sitting with someone doing an FBC, I'll pull up all these on my big
Yeah.
computer and show you these graphs,
Yeah.
okay? But your LDL, it's above optimal, but you know what? Remember, this is a stupid computer algorithm,
Yeah.
and I wouldn't mind it being closer to 90, you
Yeah.
know, okay? You know, even 99, like, but you're at 113, so 113 is not that far off
No.
of 99. Does that make sense?
So is that shot affecting any of those?
It could, like the shot could be affecting some of this. But probably more your insulin.
That's
And
what I was thinking. It's more of that.
Yeah.
Than, okay.
So I love even though this algorithm says you're right at the nitty gritty edge of being above optimal, not according to that study.
Yeah,
So according to
right.
me, you're like, pfft, right, it couldn't be better, right? All right. So, but your
Great.
triglycerides are like insane.
They're awful. And they're getting worse.
Yeah.
Like if we would draw it today, it's going to be higher. I mean, it's jumping big leaps, not little leaps. It's not even going little time. It's going bam,
So we
bam.
got triglycerides that our eye needs to be on, and we have HDL. I want your HDL, your good cholesterol, to be higher, okay?
Okay.
So we need to do what I call normalizing your lipid profile.
Okay.
Normalizing just means push this one up a little bit, this one
Yeah.
down a little bit, get it normalized.
How do I do
to have a
that?
healthy profile? Well, we're going to talk about that. And
Good.
so the thing is, but not a whole lot of normalization. Really, when I look at this, I think there's really one thing we need to do, and
Okay.
it's triglycerides. We got to get your triglycerides down
Gotta
and
get 'em down.
understand why they're high. And that I
Yeah.
think is a genetic insulin thing. So I'm going to keep skimming through this. We're going to get there. This is high, this atherogenic
And
index.
but you know what? I'm wondering if because they never were high in my life until like a year and a half ago.
Yeah, so perimenopause,
Oh,
it's
so
just
the-
an interesting,
yes.
it's a hormone tapestry, right? And if one hormone changes, these other hormones get affected. And so, we know as doctors, I believe, a lot less than we let on. We're just educated guessers.
Yeah.
And it's,
Yep.
we really are. We're really very educated,
Yeah.
but we're guessing, right?
Yes, exactly.
So, I can talk to you all about cholesterol and cholesterol normalization and heart disease is something that is dear to me because my father had double bypass heart surgery.
Okay.
He has heart disease. And it's the reason I'm in Tennessee because my parents really wanted me here to be able to help them navigate the healthcare system because they were like,
Yes.
do we do this? Do we put them on statins? What do we
You
do, right?
do not know what to do.
That's right. And so they're like, just come live with us. I'm like, well, this is like the worst state ever for me to be in because like I can't be licensed here.
Correct.
Right?
Right.
But they're like, just be a health consultant then. I'm like, Okay.
Okay, sure.
We'll see what I can do. But because then insurance doesn't cover me or anything like that. But so I know. So like last year, 2023, I went to the Family Heart Global Summit in Washington D.C. Okay, and went to this whole summit talking about LDL cholesterol. So this is a whole little brochure on LDL cholesterol and LP little a, they call it, which I saw your LP little a and it was 25, which means you're low risk, by the way. So low risk for a coronary event.
Good.
So like I said, a lot of stuff looks like you're low risk. There's just this triglyceride issue. Okay, so and insulin.
Insulin.
Yeah, and those are big deals.
Yeah.
But your profile looks more of like a genetic issue that we need to try to manage than a huge, oh my God, you're on the borderline of dying.
I see. That's exactly what I felt. I felt like I was just spiraling, and then thinking that in your head makes you feel
then
worse.
your cortisol goes up.
Oh,
and that's
listen,
not good.
stress. Oh my gosh, it's been a mess.
So, but look at this. Like this, this is your platelet to lymphocyte ratio, and it's like 93, 90, and that's awesome. So, what this means is a lot of people who these days, especially if you've done a lot of different vaccinations, but there's really no rhyme or reason to it. I've seen people who've not been vaccinated at all and they still have way high PLR ratios.
Yeah.
But basically, it's like the thickness of your blood. So like, are you going to be at risk for a deep vein thrombosis or a stroke or a heart attack because of the blood clotting and causing an occlusion? Okay.
Yes.
And this means no.
That is great.
Like this is
I have worried
this
about
might be
that.
one of the best I've seen for PLR ratios.
No way.
Yeah, it's pretty awesome. I have people in the 500s and 600s. His is way higher.
Really?
Yeah. Okay. So what does that mean?
Maybe 2 points.
So what does that mean? What does that mean, PLR ratio? Well, it's platelet to lymphocytes, and basically, plaque itself, when it builds up in the artery, doesn't typically cause the occlusion, okay, that causes the problem, like the stroke. What happens is you start getting these plaque buildup, which we can talk about in more depth later, and then it's like a fatty streak forms, and this fibrous cap forms over the top of it, and then it can, if it's unstable, it will burst. It's sort of, I envision it in my mind like a little pimple bursting, and then the fat starts splooging out of the little hole in the plaque. Does that make sense?
Yep, that makes
well,
sense.
your blood is like, that is not supposed to be happening.
Yes.
And it looks like, to the blood, it looks like an injury. It looks like a wound.
Oh.
Okay? So then what do we do when we get a wound? We get a scab.
Pick at it.
Well, no, we don't pick it. But it's like a clot. We get a little clot. A clot forms. The blood immediately starts clotting when it sees a wound.
Right.
So if this fibrous cap that is just capping over the fatty streak, if it bursts and the blood thinks it's a wound, it's going to put a clot there.
Oh my goodness.
And so it's the clotting factors in the blood, right, that will then, and then if it's narrow, because the plaque is made, then that clotting, that's a normal clotting cascade, will then occlude the vessel, okay?
Wow.
All right, so what happens is, in order to, first, it would be best if we don't have the fatty streak, then you don't have to worry about it bursting.
Right.
But, and so there's, a sequence of events here.
Yeah.
But if your PLR ratio is low, then I'm not worried, even if you have if you have plaque buildup in your artery, I'm not worried about, I'm not as worried about it occluding a vessel if it bursts.
Correct.
Okay?
Yep, absolutely.
And I'm not worried about you on a plane flight to Australia or New Zealand or something and getting a deep vein thrombosis.
I used to worry about that.
Yeah,
I really did.
Yeah, I'm not worried about that. Okay.
That's great.
Okay.
You leave.
Okay, so blood cells, I see some interesting things here, but you look very, very healthy. This is all in the healthy range. So great. Normally, all these M's, MCV, MCH, MCHC, MPV, all these M's, a lot of this has to do with B vitamin deficiencies and the health of the red blood cells and the health of the platelets.
Right.
And you look great. Okay,
Okay,
so,
great.
Good job. All right, so all of that looks great.
Even though I have that MTHR thing, they said, I mean, what is that? Is everybody getting that now? Because he has it.
Yeah.
I'm like, is that just like a trendy thing that, you don't have that? Or it's a mutation you have?
No, this is probably contributing to some of your insulin resistance, okay? Because people who have either homozygous or heterozygous, meaning they have one copy or two copies of the different kinds of MTHFR variations, depending on which one you have, which we can talk about, but you can have a more difficulty absorbing magnesium from your food, and
I see.
magnesium is going to be one of my huge recommendations for you because it's going to help you become more insulin sensitive.
There we go. Okay.
Right?
Yes.
So you have a genetic predisposition to not get the magnesium. So you can eat spinach and magnesium-containing foods. So the cows come home.
But if you can't absorb
but if
it,
your
then
intestines-
it's not going to work.
That's right.
I see.
So,
Got
so
it.
like for me, you know, I have the same thing as you, and so I, you know, get muscle cramps really easy. Like I'll if let's say I go hiking and I sweat a lot, I'll get muscle cramps that night, right, in my legs, you know, or whatever. When I was in high school, I was a swimmer, and this muscle would cramp up, and I'd be like, and I would have to push my hand out. Well,
I have to do my feet that way.
yeah. So
That's the only place that happens.
that's magnesium deficiency.
I see.
That's what that is. So I would have to stretch my hands out, and it was so bad when I was younger that I refused to use a coffee cup that had a handle on it because I
You didn't want to grab it and start it. You didn't, because that's what it did. It'll do it once you start. It'll do it. Like when I put my toes down to put a pair of pants on, I'm like, oh my gosh, it just, you
That's
know.
right.
But
Exactly.
you just did it when you were young.
Yeah, that's
weird.
Well, it's not weird. It's an MTHFR gene snip.
I must not have paid attention to it as a kid.
My whole life like that.
I've never paid attention.
So
till
now that I know that, right, I try to bypass my digestive system to get magnesium in my system.
do you do the spray or something?
So
or-
I make a foam, a magnesium
Yes.
foam that and I add a little DMSO into it. I use a magnesium chloride and I put it on transdermally.
Because I bought the spray, and you know,
feels-
for once I put it under my armpits, I put it on my feet, but then I didn't know what I was doing. I'm like, so I quit. So I don't know
Yeah,
what
so
to do.
you can buy on Amazon from
yeah.
Ancient Minerals, and there's a 7
Yes.
Minerals, or anyway, there's several different brands
Yeah.
out there, and that's magnesium chloride, which is awesome.
Okay.
And it's very transdermally absorbable compared to like magnesium sulfate, which
Yeah.
is Epsom salt. And so I make my own blend of magnesium
Okay.
foam, right? And you know, I like it in the foam better than that spray because that spray feels
The spray,
greasy and
it does.
icky.
It's weird.
right?
Yeah.
So I didn't like the feeling of it. So I then get the magnesium chloride flakes from Ancient Minerals. That's what I buy.
Yeah.
And then I use aloe vera as the water, so it's just
There
one
you
to one.
go.
And then it looks creamy, you know, but the creaminess is just a coconut oil derived foaming agent, right?
Okay.
So that it just is moisturizing, and it'll absorb in about a minute here, and then it has much less of a
yeah.
tacky feel. So I like
Yeah.
the way it feels better. And I put about 10% DMSO in it, which drives it deep into the tissues.
Oh, good.
Right.
Okay.
So then you'll sleep better if you get Charlie horses at night, or if you have periodic leg movement disorder, or if
and
you
how
have,
much do you put on? I mean, like,
just what I just did.
Just what
And
you
could
did,
Put
and
it
that was
on,
good.
Yeah, and you can put it on your legs. You can put it on your abdomen if you
Mm-hmm.
think you need more. And then this will. It's funny. It's hard to believe this, but it will calm me down. Right? Because
Really?
I'm very hyper. You probably didn't get that.
I didn't notice that at all.
No, it's very hard to notice. You got to be, paying attention. And so this will calm me down, but it also makes me it makes me sleep better and not have muscle cramps, right?
Okay.
And for you, doing a regular, if you can withstand the little bit of a tacky feeling on it,
Sure.
that would be really good for making you more, helping you become more insulin sensitive.
Okay, I need to do that.
And then as far as magnesium supplements go, this is the one that I would recommend for you for insulin sensitivity.
Mm-hmm.
It's a Da Vinci Labs TriMag, okay? And it has 3 very specific magnesiums that have been shown to help with insulin sensitivity.
Okay.
And it's malate, glycinate, and taurate. And those are the ones you want. And it also, believe it or not, will help with heart palpitations and
Now, I was having those bad in the beginning. I don't have them anymore for some reason.
the fact that you had them means to me that you potentially have a magnesium deficiency.
Dear goodness, I use it. Well, I went to the emergency room that time that I thought I was having a heart. I didn't know what was going on, but it was just, they said it was anxiety, but then I was like, I don't have anxiety. I don't know what you're talking about.
get it.
That's what they said.
So a lot of people, my clients who have heart palpitations or AFib, right? This has been shown in clinical studies, this blend to help with AFib, and their AFib goes away.
Wow.
So but for you, like there's tons of different magnesiums out there. There's citrate, magnesium citrate. There's magnesium
Yes.
oxide. There's magnesium sulfate for Epsom salts. There's magnesium chloride. There's so many magnesiums, and you're like, oh my goodness.
What do you do?
And they're all
Yes.
different. But this one is the one is the right blend for insulin sensitivity.
That's what I need.
And it happens to coincidentally be also very, very good for heart health.
Perfect.
Okay.
Yep, I need that.
And trust me, there's other ones. It'll also help you sleep if you take it before you go to bed at night. So, like
Yes.
for you, for insulin sensitivity, I would want you to take 2 a day, 1 in the morning and 1 before you go to bed.
Okay.
And this is going to help contribute to increasing your insulin sensitivity, which will hopefully lower your triglycerides.
Thank goodness. Yes.
I don't know how much more time we have, but we should
We probably cut off because it's already.
say this is the end of phase 1.
I agree.
And I mean,
Yeah.
we we got to page 12 out of 67.
That's not bad.
And you get 76 pages?
67.
67. He's
But they're not
dyslexic.
all but we have so much more to talk about. We didn't even get to how to other things. So
So you can see, Amanda, all that she has to spend time with you.
Yeah.
And every person out here.
I know.
How in the world? There's only one of you and I'm
Oh my goodness.
And that's why she wants to try to teach people and maybe.
Oh,
help
it's needed
where-
so
where
badly.
people can help themselves more.
Well,
so than-
I mean, I have thought that I'm dying. How long have I been sick?
you
I've been
actually
going
look-
down, man.
you look really good, and like I need to
That
understand.
is
more
not
of
what
your
I've been.
symptoms.
That is not
Is
how
the-
I felt.
Is her getting tired after she eats or in the evenings because of her insulin?
Probably, yeah.
I mean, we're talking-
that's contributing, and I think there's a perimenopause factor here too, and probably some absorption issues in the gut, and so we have a lot to talk about.
Yes.
Yeah.
Yep.
Sounds like if I'm worse than you, we got more to talk about.
All right, well, until next time then.
Until
huh?
next
Phase
time.
2.
Yeah, absolutely. My God, that is great. I feel better now. That I mean, just knowing that.
You're actually remarkably healthy.